This video will describe the technique for splinting. Splinting immobilizes injured extremities to prevent further injury, decrease pain, and allow for healing. After reduction of a dislocated joint, splints maintain proper positioning. Stabilizing a fracture with a splint keeps bones in their proper alignment. Splinting also allows for swelling to decrease before the placement of a cast. Patients with strained ligaments have their extremities splinted in the position of function to decrease pain. Gloves must be worn while using splinting materials and when open wounds are present. You should evaluate the need for a gown and face and eye protection. Informed consent typically requires discussion of the details of the procedure, alternatives to the procedure, and potential risks or complications of the procedure. Instruct the patient that after the splint is applied, to return if there is worsening pain, swelling, discoloration, difficulty moving fingers or toes, or change in sensation. Indications for splinting include temporary immobilization of sprains, fractures, and reduced dislocations, tendon lacerations, control of pain, and prevention of further soft tissue or neurovascular injuries. There are no absolute contraindications for splinting, but consider prior to placing a splint the likelihood of severe swelling, as even splints can become restrictive with severe swelling. If neurovascular compromise is present prior to splinting, attempt reduction before placing a splint. Complications from this procedure are uncommon and include neurovascular compromise, compartment syndrome, and pressure sore. Equipment needed for performing splinting include gloves, basin or casting sink, stockinette, cotton padding, plaster or fiberglass rolls, elastic bandages with clips or tape, heavy-duty scissors, water, and sheet. Fully expose the patient's injury prior to splinting. All injuries to the extremity must be identified before splinting. Evaluate pulses, motor, and sensory function, and treat skin or soft tissue injuries prior to splinting. Drape the patient with a sheet to protect clothing prior to splinting. Remove all jewelry from the extremity. Administer analgesics or anesthetics prior to splinting or reductions. Reduce fractures or dislocations before splinting. Position the patient in such a way that allows them to be comfortable but gives you access to the extremity. Place a check underneath the patient's arm and assure patient comfort. Then measure the stocking to the length of the patient's extremity. If any fingers are to be exposed, be sure to cover the fingers in the stocking as well. Measure the length and cut accordingly. A small slit on one side of the stocking helps with proper fitting. Then roll up the stocking and slip it over the patient's extremity. Cut a very small hole in the stocking to allow the thumb to pass. Smooth out the stocking to assure that there are no wrinkles. Use the cotton padding, often referred to as fluff, and wrap the arm in a distal to proximal fashion. Be sure to overlay the layers when wrapping. Complete 2 layers of the cotton wrapping, this time going from a proximal position to a distal position. Measure how much plaster you will need by laying a single layer of plaster over the area to determine the length of the plaster. You will overlap the plaster, usually 5 to 6 layers, depending on the splint type. Immerse the plaster in water to activate, and squeeze the excess water, applying a downward motion. It is important to not crumple the plaster because it will stick to itself. The plaster is now ready to be placed. Lay the plaster over the fluff and mold it into position. Cover this layer of plaster with another layer of cotton padding. This usually requires 1 to 2 layers of cotton padding. When satisfied with the cotton layer, fold the stocking over the edge. You are creating a bumper. Repeat on the opposite side of the splint and cover with a cotton layer. When you get to the thumb index portion, you can twist the cotton layer to catch the stocking edges. Using an elastic bandage, wrap the entire splint from a distal to proximal fashion. Be sure that the patient can still move the thumb and index fingers at this point. Secure the bandage with metal clips. Ensure that the extremity is in an anatomical position. As the plaster dries, be sure to mold it to the desired position. Instruct the patient to remain still until the plaster dries. Check the neurovascular status of the hand by lightly touching the fingertips or checking capillary refill. You have now successfully completed placing a volar splint. An X-ray may be used to verify positioning. Patients should receive both verbal and written instructions on the importance of elevating the injured extremity to decrease pain and swelling, and on splint and cast care and precautions. Ice can be applied for 15 to 30 minutes at a time over a cast or splint. Strong opioids should be used with caution during the first 2 to 3 days after splinting because they can mask pain that would otherwise prompt a follow-up visit. Patients should be educated to continually check for signs of compartment syndrome and report immediately to an urgent or emergent care facility for removal of the cast or splint at the first sign of vascular compromise. They should also refrain from getting the material wet or pushing objects inside a cast to scratch. Time of follow-up and length of immobilization are extremely variable, depending on the site, type, and stability of the injury, and on patient characteristics such as age and compliance. Most splints and casts require initial follow-up within 1 to 2 weeks after application, and most fracture guidelines estimate 4 to 8 weeks for healing. However, all injuries must be assessed, treated, and followed on an individual basis. If you need to remove the splint, first begin by removing any safety clips or metal clips. Then start unrolling the elastic or ACE bandage. Identify where the plaster is located underneath the cotton layer. Then, using safety scissors and avoiding the plaster, begin cutting the cotton and sleeve layer. Carefully remove all of the cotton layer, the plaster, and the sleeve in one piece. Reevaluate the patient immediately with an X-ray to verify positioning.